know that we need to know about the mineralocorticoid status and the androgen status to really get the idea about how this particular individual will land into and which form of CAH could this be. So if it is mineralocorticoid deficiency and there is androgen deficiency, so we are talking about proximal defects like star, side chain cleavage, 3 beta HSD and POR. If we have androgen excess with deficiency, we are talking most commonly with 21 hydroxyl deficiency, rarely with 3 beta HSD and POR. Now these two are in both places because they will have DSD in both XX as well as XY individuals. Next scenario is that if you have isolated deficiency in aldosterone, you're dealing with a 11 aldosterone synthase defect, which is a milder form of overall process. Now, if mineralocorticoid is normal and androgen is low, this is isolated defect in testosterone production, that is 17 beta HSD deficiency. If you have got normal levels of mineralocorticoid but androgen is more, this is like aromatase deficiency. Finally, if the androgens are high and if the androgens are low and mineralocorticoids are high, this could be 17 hydroxylase deficiency, XYDSD with hypertension. If it's excess of both mineralocorticoid and androgen, we're dealing with 11 hydroxylase deficiency, XXDSD or precocious puberty in boys with hypertension. And finally, if you have excess mineralocorticoid with no effect on androgens, we are dealing with probably 11 beta HSD defect. So this framework of this slide will really help you make the diagnosis in most cases and classify it appropriately. So we'll start one by one. Dr. Alapan, we have a 3-month-old boy with micropenis and inguinal hernia. Advice for surgery, and this is a clinical picture. There is also microcephaly and there are other features. So now what do we see in the reports? How do you use this algorithm to get the diagnosis? We'll look into that. There is hyponatremia and hyperkalemia. So what is the mineralocorticoid status?
It is deficient.
So it's deficient. Next step is to look at androgen. What's the androgen status in this case?
Androgen status is low.
Because there is micropenis, although there is no clear-cut atypical genitalia. So now the next question is cortisol is also low in this scenario. So what is the likely possibility here?
This hernia is there, androgen is deficient, and mineralocorticoid is also deficient.
Hmm.
I think the phenotypic appearance of hyperplasia after years.
Yeah.
This would be a very obvious.
Yes. So clinically, if you go by that, can it be 3 beta HSD, star, or HCC? Do you think, first of all?
Unlikely to be used.
Very unlikely, because they will have real atypical genitalia. If they are mild, they will not even have micropenis. Then if you talk about non-classical forms of star defect, as we talk about that boy who presented later with adrenal insufficiency, their penis will be normal. So if you have micropenis, it will have also hypospadias. But in Smith-Lemeli-Opitz, you may have a milder picture because there are non-cholesterol, other ways in which you can get the cholesterol in. So this in this scenario clearly looks more like a Smith-Lemeli-Opitz syndrome, and lipid profiles showed that the cholesterol levels were low in that regard. How do you treat SLO?
We can supplement for the dietary cholesterol.
Yeah.
To 30 milligram per kg per day.
So there is special supplement, special nutrition is there. There is also a degenerative disorder beyond adrenal. So neural involvement also may be there. So it's a disorder you need many more follow-ups. Next case, Dr. Sandeep, is a 14-day child with DSD. And what you can see is that there is palpable gonad. There is no uterus. There is XY. So this is a XY DSD. So now the first question is, you want to know about the mineralocorticoid status. So now mineralocorticoid status, there is hyponatremia and hyperkalemia. So what do you think is happening here? So which group you're looking at? Mineralocorticoid is deficient, androgen is
deficient.
So what are we looking at in this scenario?
Since there is DSD, it could be optimal defects like star SSC.
Star SSC and 3 beta HSD as well. Now, if you talk about star SCC and 3 beta HSD and you compare those two, which one will have more severe atypical genitalia, star or 3 beta?
3 beta.
3 beta will have more severe.
Yes.
Why? Yeah, carry on.
Because star is a two-hit defect.
No, 2 hit means that hit has already happened. Either you don't have hit, then you won't have any problem. But if you have a problem, it's gone. 3 beta, what is happening to the testosterone levels? You have some conversion in the periphery. Yes, sir. So your testosterone in star will be less than 100, more like 0. While here it will be more than 100, then therefore you will have some virilization. So this sort of a virilization, which is not entirely normal, but it is definitely less, but no, more than somebody who has a complete female appearance, is more likely to be a 3 beta HSD defect in that. Just as we discussed at the case whom we saw just yesterday, in which the testosterone levels were also high, DHEAs are also high. So that is going more in favor of a 3 beta HSD. So in this scenario, you are clearly going towards a scenario of mineralocorticoid deficiency and androgen deficiency. And then this is going more in favor of a case of 3 beta HSD where 17 OHP may be mildly elevated. Now, testosterone level in this case were reported as low. But generally, the testosterone may be normal or high in that scenario. So be cautious. Look at the whole clinical picture and then go from that perspective. So, Nimisha, 3 week old child with failure to thrive, the most classic example, I think. So, you are seeing a child who has got no palpable gonads, has atypical genitalia, has Mullerian structure, and there is hyponatremia and hyperkalemia. So, if you use that algorithm, where do you place this child?
Mineralocorticoid deficiency,
Yes.
androgen excess,
So most likely cause.
21 hypoxia.
So this is a classical picture of 21 hydroxylase deficiency. As I said, now if you compare 21, now I was talking about star versus 3 beta HSD in a XY In XX DSD, will 21 be more affected or 3 beta will be more affected?
21.
Why? Because again, 3 beta, it's not being produced that much. It's just that there is a peripheral conversion. So levels will be like 100, 120. In 21, the testosterone levels can go really high. So 21 will be more virilized. Within 21 and 11, which is more more virilized? Alapan? Why? Yes.
Some amount of glucocorticoid action is also there in corticosterone and other production.
So 11, you will have many more androgenic products which will be produced, and this is well known that 11 will present to you like a normal male. If you have a normal looking male with cryptorchidism, with Mullerian structure, first look at blood pressure. It is going to be most likely a case of 11 hydroxylase deficiency. So within XDSD, so to speak, with salt wasting, 3 beta will be slightly milder and 21 will be more severe. But you cannot always just based upon the severity. There is no like clear demarcation lines of Prader below this is 3 beta, Prader above this is 21. It may happen, but if you compare the overall virilization, 3 beta will be less virilized, 21 will be more virilized. Yes, Vibha?
In 11 hydroxylase, after what age the blood pressure increases like?
Yes. So 11 hydroxylase, the blood pressure typically will start increasing by 2 months, something like that. Once the infancy is over, your blood pressure will start increasing on that. And many patients may actually present quite late with hypokalemic paralysis also. So both 17 and 11, if nobody measures blood pressure actually. So they will come to you and then you will measure, or they may come to you with hypokalemic paralysis also in that regard. So this is a classical case of 21. So there are many more pathways which are open as compared, because the block is much distal. So you will have many more other products which are going to be shunted towards that regard. So 11 is more affected in terms of virilization. So if you now ask me about these three, let's say POR will be least. 3 beta HSD will be number 2. Then you will have 21. Then you will have 11 in terms of increasing amount of virilization. If you go on the other hand, feminization, the highest will of course happen if you have no star, no site length. That is the classical presentation of sex reversal. That was the term which was used. Or you can say apparently normal looking female. SLO, severe cases can also have complete sex reversal. But 3 beta HSD will never have sex reversal. So if you have an individual who is looking like complete female, the only thing you find that there are gonads there, it cannot be 3 beta HSD.
Sex reversal infantilism, both are
No, sex reversal means that you have a male who is presenting to you like a normal female. While infantilism means that there is no pubertal development at all. So sexual yes, yes, you can use it. Yeah. So when you are saying that somebody who has a normal looking male, like a Prader 5, sometimes you will get CA, that you can say it's like a sex reversal.
Sir, in 17 hydroxy is basically that particularly I use the sexual infantilism.
It is for everybody. Yeah.
For both boys and girls, boys it will not be girls.
It will basically girls.
Girls,
Yeah.
girls.
Mhm. So boys will have atypical genitalia. They will have problems in much more in that perspective. So that's a specific term people have used. That's why I often emphasize on that. It gives you a clear picture. A girl who has hypertension, no breast development, and then in that scenario you will think of 17 hydroxylase development. So this is a classical case of 21 hydroxylase. I think nothing much to worry about. Dr. Vibha, we have a 1-year-old girl with atypical genitalia. She is Prader 3. So there is definite virilization is there. There is no gonads and uterus is there. So this is a X6 DSC. Now you will look at the mineralocorticoid status. So here the potassium is 3.1.
the lower side.
Yes.
It's going towards the mineralocorticoid axis.
Yes. So mineralocorticoid is more and you have got androgen is more. So this is a classical case of 11 hydroxyl deficiency. Very importantly, because BP is often not taken in these scenarios, you will miss it. So getting a potassium or getting a PRA will give you a clue. What will be the PRA level you think in this case? Absolutely low. So you will have low PRA and you will have low LDO. Both will be low. So this is like behaving like an apparent mineralocorticoid excess where DOC is the mineralocorticoid which is there. So this is a classical case of 11 hydroxylase deficiency. Dr. Alappan, 8-year-old boy with early puberty. Height is very short, bone age is fused. So already bone age is fused. The child has stage 4 pubic hair. There are no palpable gonads. So do you think this is bringing you some bell? We have been discussing about this.
That is not present, so we have to look for the Mullerian structure whether it is present or not.
Yeah.
First,
so Mullerian structure is there.
So this is basically a girl child who is virilized, completely virilized, but with adult 5. And so this is a case of
XX DSD, and they may present to you with precocious puberty. I have seen patients who presented to me with cyclical hematuria because of menarche around 12-13 years of age. That's the typical presentation. So now in this case, what you are seeing is that there is hypokalemic alkalosis. So what are we thinking of? Mineralocorticoid is
excess.
Mineralocorticoid is excess and androgen is so only one diagnosis. So if you use this algorithm, 90%, 95% cases, you will get to the diagnosis that you're looking at. So this is 11 hydroxylase deficiency. Of course, DOC, genetics, whatever you're looking at, you will get the diagnosis. How will you treat this child?
Patient,
yeah. Yes, fluorocortisone should be avoided. Will you give spironolactone? So sometimes sustained hypertension may predispose to persistent hypertension even when you have taken care of hydrocortisone. So then you can use either spironolactone in the setting of females or you use a specific agent like eplerenone in the setting of a male individual. Gender of rearing?
Like a boy, levels were higher.
So gender identity is usually male in that regard. So all CH are supposed to be having a preferred gender of identity as female, except for this Prader 5 and plus minus Prader 4. Prader 4 also you may be confused what may happen in their brain and the fetal androgens in that perspective. So what all you will have to do in this case? So you have given hydrocort, you have given whatever BP is controlled management wise, surgical management. So mastectomy, oophorectomy and everything has to be done. Hysterectomy. Yeah. So this is like a precocious puberty. So you can't do anything on it. Yeah. Hmm.
Very harsh voice.
Hmm, hmm, hmm.
Like, oh,
I'm not aware of it. Maybe the only thing which can be done is that, of course, vocal cord surgery and all, which is probably too much, probably in that regards. So in this case, I think they are living as male for the last 8 years, and behavior is like male, gender identity is male, so should be a male gender of rearing. Of course, precocious puberty, they will have other features which you can't help it out. Hopefully, by giving hydrocortisone, you will expect that testosterone levels will come down. So all that aggression part will come down.
So in this case,
So,
in this case, should surgery be done at this age, or we should wait for up to 18 years? Till then, the child should take his own decision regarding the.
that's a very difficult scenario, but then you will have hematuria very soon, and maybe at 8 years, if the bone age is advanced, you never know. Immediately, you may have hematuria. I've seen patients 8, 9 years of age. So then you have to give JNRH analog. It's like a very, very complicated decision. So of course, there are so many legal issues, but this is one scenario I think wherein we may be weighing in our efforts, like 5 alpha reductase deficiency, partial AIS, 17 beta HSD. Those who virilize during puberty, we say you should go as a male. The problem here will happen is, now once you start hydrocortisone in them, what will happen to his testosterone level?
Testosterone level will start to loss.
So you will have to give him testosterone later also. So this is important. It's not just that you have removed ovary, you have removed everything. You also need to give them testosterone later on. And will they be fertile? Of course, there is no gonads at all, so they won't be fertile. Would they be fertile as a female? Very unlikely. The anatomy is such and everything, so it's not going to work out that way. And such high androgen levels, we talked about aromatase deficiency, that intra-ovarian hyperandrogenism may destroy the oocyte. So what will happen in this case also we don't know. Okay. So we'll move to the next case, Dr. Sandeep, 14-year-old girl with delayed puberty. She is short for the family. She has got no breast development, no pubic hair development. Blood pressure is high. So what are you thinking of? So what is happening to her? Yes, the mineralocorticoid levels are high. The next, of course, which is proven with hypokalemia, and there is also an interesting twist. This girl actually has a inguinal gonad. So what do you think is happening?
Very structures are
Yes, so Mullerian structures are absent and karyotype is XY. So you have got excess amount of mineralocorticoid and androgen levels are deficient. So this is 17 hydroxylase deficiency. This is the mirror image of the previous case. There you had a XX DSD with hypertension 11. This is XY DSD with hypertension, which is a 17 hydroxylase. So in this case, what will you do? Gender of rearing? What will be the antenatal levels of testosterone? High or low? Because it never had the capacity, the child doesn't have a capacity to produce, so there will be no antenatal exposure to testosterone. So rear as female will be the best. Of course, you will have to think of gonadectomy as a thing to do at, and of course, fertility is not going to be there because there is no Mullerian structure. But gender of rearing could be female. You have to start hydrocortisone again, and that should decrease the blood pressure. But sometimes you may have to give spironolactone also in that scenario. So 17 hydroxylase deficiency is there.
we can say.
Yeah, so these are all terms. That's why these terms were a bit removed because they are controversial and confusing. Better to say XXDSD, XYDSD. But if you talk about, they are more very apt terms that they will explain to you. This is a sex reversal. This is a girl who is a boy who is looking like a girl completely. So what else is sex reversal? So these were terms which were easy to understand, but because of the obvious sort of a pejorative nature, because it looks bad when you say these terms, they have not been used. Yeah. 4-year-old boy with recurrent stroke. So now we're talking in a different direction altogether. Blood pressure when you found was found to be high, Dr. Nimisha. Potassium is low. So there is mineralocorticoid excess. Now the next step, of course, will be to look at the androgen levels. There is no ambiguity. There's no atypical genitalia. Genitalia is normal. So what do you think? Yes. So we are dealing with a case where you have got excess levels of androgens and you have got normal level of the excess level of mineralocorticoid with normal levels of androgen. So we have label 11 beta HSD. Of course, you have to go ahead and work up for everything of low renin hypertension. So we'll have another class on increased aldosterone effect. So your aldo is low, renin is low. What are the other possibilities? So within pseudogenic defect, 11 beta HSD of course is the most important cause. What are the other differentials? Would be if you have post aldosterone problem in the epithelial sodium chloride channel that can cause that. You can have Liddle syndrome, that could be the other scenario. So that will be the good differential, and there the responsiveness to spironolactone will give you a clue. So who will respond to spironolactone? Liddle or 11 beta HSD? This will respond because here the mineralocorticoid is working. Spironolactone is an anti-mineralocorticoid. So spironolactone responsiveness is preserved in the setting of 11 beta HSD2 defect, while amiloride is the treatment of choice of the ENaC defect or the Liddle syndrome, because amiloride is the same, it blocks the same channel. So aldactone response was present, it was 11 beta HSD2. So looking at these two combinations will give you the clue. Dr. Vibha, 6-month-old girl with failure to thrive, there is hypokalemia, hyponatremia and hyperkalemia. So we are now going in the other direction. So we have mineralocorticoid deficiency and there is no pigmentation. The genitalia is also normal. So what are you thinking of? Yes. Yes. So we are looking at the defects in which the aldosterone, there is an isolate impaired aldosterone effect. Something like we had increased aldosterone effect. This is impaired aldosterone effect. So either the problem is in aldosterone synthesis or action. So as you said, we have to go for the other levels. Cortisol we do anyway just to rule out adrenal insufficiency, which was normal. Aldosterone levels were low. So this was CYP11A defect. Now, how do you manage CYP11A?
So, can give spironolactone to prevent the failure of the extra.
So you will give spironolactone. You will give fluorocortisone. It's the easiest to treat. You just have to replace them, and you need to give just physiological fluorocortisone. How do you manage the? I was going to ask the next question more importantly. So that is pseudo hypoaldosteronism. How do you manage? And more important part of management, salt is most important. Then you may need to give soda bicarbonate in some cases, as we were giving in that girl. So here you give aldosterone. That is very, very easy to treat in that regard. So Dr. Alappan, 3-year-old boy with failure to thrive. Now this child is different. There is pigmentation, which is there. Brother died at the age of 2 years. There is a clear-cut history there. There is hyponatremia and hyperkalemia. Now, how do you go about this?
Extra deficiency,
And genitalia is normal.
extra deficiency is there, but
Genitalia is normal.
the a 3-year-old boy.
Hmm.
So we have to look for the androgen will be excess because the
Why? So you have deficiency of mineralocorticoid. Androgen seems to be normal. It doesn't have precocious puberty, nothing. So do you think this is 11 aldosterone synthesis defect?
no pigmentation in that.
So that is an important clue to look at in that perspective. So what do you think is happening here?
It could be a case of 21 hydroxylate deficiency because pigmentation is there.
21 hydroxy deficiency presenting at 3 years. Very, very unusual. If it's salt wasting, they would have died by 2 months, 3 months. So yes, you are in the right track. It could be any other cause of adrenal insufficiency, like adrenal hyperplasia congenita, AHC could be there. Mild form of star defect can be there. Other scenarios can be there. So cortisol is low in that scenario, and this shifted towards that side. and this child actually is a child who comes to us with star defect, whom you are thinking of other causes and proved to be star defect. So this means that it's not necessary that you need to have a aldosterone androgen deficiency in everybody. There are milder forms of star also which are there. So this is like a adrenal insufficiency. So pigmentation is a very important clue in that regards. Dr. Sandeep, 16-year-old girl with primary amenorrhea. She is tall. Height is 166, but there is no breast development. There is no pubic hair development. Inguinal gonad is present. So what do you think is happening? So this is XX or XY? XY DSD, of course. BP is not high. So what are you thinking? FSH is 120, karyotype is XY, which we expected. So what is happening to mineralocorticoid? Is normal, androgen. So this is a classical case of 17 beta HSD, which may look like complete female. So this is again example of sex reversals, quote unquote. So this is 17 beta HSD in a XY individual without hypertension. This is going to give you the clue on that regards. How would you manage them? Estrogen, because she is female completely and never ever exposed to testosterone. So the gender of rearing will of course be female only, because this is clearly, and gonadectomy has to be done later on. So this is 17 beta HSD presenting to you as girl completely. 3-month-old child with atypical genitalia, Dr. Nimisha, and you can see that there is no palpable gonad. There is uterus which is there. XX is the individual. So this is a mineralocorticoid. So androgen is excess, but there is no pigmentation, and sodium potassium is normal. So what do you think here? This is the most likely scenario for aromatase defect. You may also have disorders like mild POR sort of a situation can sometimes present to you like that. So this would be a milder variant in which you don't have any salt wasting, which can present like that. So 17 OHP is normal. There was history of maternal virilization which gave a clue of aromatase. 3 beta star to have female genitalia. Star definitely may have female genitalia. 3 beta is more likely to be DSD. It's unlikely to be a complete female at all. So Dr. Varsha has responded to many of those questions. Dr. Medha, meaning of post-extraction? Extraction means that we do a free level. We have removed the sulfated fraction from there. Cortisol not confirmative. This is because affected by other stimuli. Yes, cortisol, there are a lot of other issues. And the amount of cortisol production will depend upon how much activity of the enzyme is there. So if you think of a blockage, the 17 OHP will give you a much better picture. So this is how you will identify.